Brought to you by Medical Communications Network.
Namaskar, welcome to this special weekend edition of Medical News. The topic for today's discussion is a big fight which has been raging on between cardiologists and cardiac surgeons for a very long time. Should a patient go in for an angioplasty or a bypass surgery? Depends on the type of expert you would consult, say many patients. Well, joining us today on this edition of Medical News, we have with us immediately to my right Dr. O.P. Yadava, who is Head of Department Cardiac Surgery at the Sir Gangaram Hospital. Further to my right is Dr. V.K. Bahl, Professor of Cardiology at the All India Institute of Medical Sciences. And to my extreme right is Dr. Jagdish Prasad, Chief Cardiac Surgeon and Medical Superintendent of Safdarjung Hospital. I welcome you all to Medical News.
Thank you.
Dr. Bahl, you are outnumbered here, sandwiched as you are between two cardiac surgeons. Okay, doesn't matter.
Yeah.
When do you decide that a patient should go in for an angioplasty? Let's start with the clear-cut indications.
See, I'll give the indications for a coronary revascularization, that is bypass and angioplasty. You should look into three things. One is there should be a coronary vessel which is narrowed significantly to produce a exercise-induced ischemia. That means the blood vessel which is supplying blood to the heart is not able to supply adequate amount of blood when it is required, when exercise or emotions, when the heart requires more blood. Patient may have symptoms because of that or may not have symptoms. So once you have taken a fundamental decision that patient requires some form of coronary revascularization in addition to medical treatment which is receiving, then we look into the coronary anatomy. That is where the narrowing is. If it is a single vessel narrowing, it is a short segment narrowing which we call so-called type A lesions, we recommend these days patient to have a coronary angioplasty. But this is a too simplistic a view. We don't treat coronary arteries, we treat patients. So we have to look into the whole profile of the patient. What is his age? What his left ventricular functions are? What additional disease he has, whether he is a diabetic or non-diabetic. So this is the whole profile has to be looked into. I can't give a simplistic view that this patient should go for bypass, this patient should go for
No, we were starting with the
angioplasty.
clear-cut indications of angioplasty. You said single vessel, you said a short lesion. What else are the clear-cut indications which nobody would contest?
Similarly, suppose patient have a left main coronary narrowing. He should go for bypass, though the angioplasty is lately being tried in that subgroup also. But that is a patient which most of us will send for a bypass surgery.
We'll come back to you, but Dr. Jagdish Prasad, if you could quickly take us through the clear-cut indications for a bypass operation.
See, bypass operation where, as Dr. Bahl has told, that one patient should have a diffuse disease and more than one vessels. Like triple vessels, we usually go for bypass surgery. The vessels with like significant ischemia, means treadmill test is strongly positive, and you say that disease diffused, you go for bypass surgery. And as he told that he is suspecting calcified lesions in the coronary artery, you must go for bypass surgery. Left main lesion, as he has told that even it is single vessel disease, you should go for bypass surgery. And I think any patient who has a 100% lesion, even two vessel disease, 100% should go bypass surgery. They can't go for angioplasty because the catheter cannot pass through it. So they should go for angioplasties.
Okay, Dr. Yadav, which are the gray areas? Where is the controversy?
Well, currently the controversy comes in, virtually in any and every area. But I would say multivessel disease is a controversial area. Juxta left main, that is a block which is present very close to the left main coronary artery, block which involves bifurcation or division of an artery into two major branches, and if the block involves the origin of both arteries, that's a gray area. Long segment block rather than a localized short segment block, long segment blocks are a gray area for angioplasty versus bypass surgery.
What would your take be if the patient came directly to you?
Well, there are two ways. I mean, if you look at ulterior motive as a cardiac surgeon, obviously the answer is bypass surgery, but the decision has to be taken. We practice social medicine. So we have to look at, what the patient's financial status is, what is his intellectual power of follow-up. I mean, bypass surgery, lesser follow-up is required as compared to an angioplasty. What his paying capacity is, what his age is, what are the chances that this patient is likely to come back because of the recurrence of the disease process. So all those factors are taken into account when you make a decision, and the decision is customized to the needs of an individual patient. There are no guidelines that look 2 and 2 is 4 in medicine, never ever they are 4 in medicine. It has to be to the individual patient's needs.
Which is again subject to a lot of subjective interpretation.
It is. I mean, the same disease process, a particular person with, say, medical management, and you wouldn't say bypass or angioplasty. I mean, you have included only bypass and angioplasty in discussion. I wish, there was an inclusion of a clinical cardiologist who would say that, look, we want only medical management. And if it comes to an interventional cardiologist, the tendency is to go for angioplasty, and if it comes to a surgeon, the tendency is it is not malpractice. It is subconscious tendency to advise the procedure that you are more confident and competent in.
So,
If you have to pitch in, if you take a simplistic view with Dr. Jagdish Prasad said, a totally occluded artery. Now look at a scenario when patient comes with the acute heart attack and a totally occluded artery. You like to open the artery with balloon. The same totally occluded artery patient comes after 6 months, a year. You don't want to open it with balloon. You want to refer it for a bypass surgery if a revascularization indicates. So here is a simple same lesion, same artery, but the scenario is different. So don't forget the patient in these games of single vessel, double vessel, triple vessel.
Okay, now coming to the double vessel and triple vessel disease, what is your stand on multiple vessel coronary artery disease? Do you think angioplasty has a definite place? Because this is an area of much difference of opinion.
Sure. Whenever we take a decision of angioplasty or bypass, we should know that both should agree, that surgeons and cardiologists, that they can do their job. That means I can open all the vessels which are occluded, all the 3 arteries, wherever the obstruction is, and surgeon feels that he can bypass all the segments. Because once we are not equal, like surgeon thinks he can bypass more areas than I can open it, then the decision goes for bypass. Suppose having that equal decision, then it comes the trials. The whole medical science is based on a controlled clinical trials. It's not based on a single patient's anatomy. And there have been several trials on this aspect, starting from Rita, East, Cabri, Bari, to name these. To confuse the people more, we have more trials.
But what have the results said? What have they indicated? That for multiple vessel disease, angioplasty has a definite place?
If you want to put it in too simplistic a term, I'll say that short-term results with angioplasty are as good as bypass surgery, or even better, because bypass has a mortality, whatever it is, 2%, 1%, 5%, depending on the
short-term results are better than bypass surgery. Well, we'll take a short break at this point, and we'll come back and ask Dr. Bahl what exactly is the long-term outlook on angioplasty cases. But that after a very short break. Stay with us. Welcome back. You're watching Medical News, and today we're discussing the benefits of angioplasty versus bypass surgery. Also in the discussion, we'll look at the new modalities which are opening up in both the fields. Before the break, Dr. Bahl from the All India Institute had said that the immediate short-term results of angioplasty are much better than bypass. Dr. Bahl, what about the long-term perspective in terms of both the cost and in terms of revascularization which might be necessary?
See, if you look at the initial trials, controlled trials using only a balloon, I'll say the long-term results of surgery were a shade better than angioplasty, because angioplasty with a simple plain balloon has a biggest problem is restenosis. That means 30%, a magic figure of 30% patients come back to you again a narrowing. So that takes away the advantage which immediate angioplasty has over bypass surgery over a longer period. But similarly,
Dr. Yadav, reason enough for you to recommend bypass?
Yes, certainly. First thing, Chandrasekhar, I'd like to correct you. If you go back on your tape and see what Dr. Bahl said, Dr. Bahl very categorically said that the short-term results of angioplasty are same as that of bypass surgery. He never said they are better. And I like
Dr.
to
Bahl,
contest
did you say
that.
better? Short-term results of angioplasty, are they equal to
yes,
bypass?
as of today's technology, I won't have a 5% mortality in my lab.
So it's better than bypass?
Sure.
Well, I stand vilified. So he says it's better. Now coming back to what I asked you. Would you say that's reason enough? 30% revascularization, I mean, it's necessary. 30% of patients come right back to you. So would you say that that's reason enough for you to go for a bypass?
Well, I won't say exactly that it's a reason enough, because we also have to take into account the patient's social status and his financial paying powers, as I talked to you, and that's very applicable in our country.
Okay, assuming that a person can afford both, he wants to go in for the best treatment. He wants to go in for something which would be best for him. Assume that he can afford either angioplasty or bypass surgery. What would you recommend?
Well, if a patient has a single vessel disease, which is not, as I told you, a critical coronary anatomy left main or juxta left main, then I would advise him by angioplasty for a single vessel coronary artery disease for the simple reason, because I know that none of these treatment, either angioplasty or bypass surgery, are full cure. The patient is going to come back with a blockage, whether it is bypass or angioplasty, because his basic disease process has not been answered with, and progression of the native disease will take place. So if you have a single vessel or double vessel which you can open with angioplasty, and you have got a 30–40% block in the third artery, and I expect this patient is going to come back, then I would like to offer him angioplasty, buy some time, and then offer him bypass subsequently as a more definitive procedure later on.
What about multiple vessels?
Multi-vessel disease, yes, certainly. I strongly feel, and I try to be very, I want to withdraw myself from the commercial angle of bypass, and I would advise multi-vessel patient should go for bypass surgery, certainly. Big yes to bypass.
Dr. Bahl.
In certain subgroup, yes, like when we used to use only balloons, diabetic patients, there was a alert from Bari group that all diabetics should have surgery because the results of surgery are long-term results are better than angioplasty. Having said that, now we are no more doing a plain balloon angioplasty. We are putting the stents. So here comes the other variable. So now you have to compare multi-vessel stenting versus bypass. So the era of multi-vessel balloon angioplasty is already history.
Okay, Dr. Jagdish, multi-vessel stenting versus bypass.
See, whether you're putting a stenting, as Dr. Bahl told, that he takes 30% comes back. If you do multi-vessels graft, if you have, suppose he had done three vessels, so if you multiply 3 into 30, 90%, chance of getting 90 No, I'm just so if you take the stent, now I just stent has its own indications. Like patient has a 3 vessels block, and he will not like to put a stent in all the 3 vessels, because even when he is pushing 3.
But he's saying precisely that. He said I can put stents in all the 3 vessels.
I don't know what is the long-term result of the stent, because I think that as far as we know, that if you do the revascularizations today by the surgery, the patients remains, all the vessel remains patent when you're putting the arterial graft for 10 to 12 years. Whereas the stent, I don't know how long.
Okay, Dr. Yadav, your take on that.
Well, let me start de novo and say that we have to look at our own results and not look at the trials that we have quoted. All these trials are coming from the Western world. It's a common experience that we have diabetes, which is more florid. We have smaller coronary arteries. We have more diffuse disease. Now, all these make restenosis or reclosure of the artery more likely in these patients. So whenever we are talking of stenting or multi-vessel angioplasty, we have to talk an Indian scenario. And the very fact that even today, I don't think there is much debate. Even most cardiologists today are sending multi-vessel for surgery. If you look at last year's own statistics of this country, which have come out from the angioplasty registry, only 9% with multi-vessel disease were taken up for angioplasty. And multi-vessel 9% means even double vessel. Now, if you look at only triple vessel, then the figure would be lower. So you have to really look at your own statistics, and I think in an Indian scenario where social aspect of medicine has to be kept strongly in mind, and with these disease processes I have mentioned, which are going to make restenosis more likely event, definitely 3-vessel disease bypass.
Dr. Bahl.
No, that figure of 30% I quoted was for plain balloon angioplasty. With stenting, it has come down to say 10 to 15%, and it is coming down with the recently available drug-eluting stents.
Okay, no, but in multivessel disease, he's saying only 9% are probably ready for angioplasty. I mean, not more than 9%.
What he is quoting is 9% of all angioplasties were for multivessel angioplasty, but that is not a question.
No, do you agree with this figure? Would you say that multivessel disease?
Figure is there.
What is your experience at the All India Institute?
The problem is we have to look into what we are debating. We are debating. I agree that I can do angioplasty of all the lesions. He agrees that he can put a bypass of all the lesions. He agrees that he'll use the best technique. He's using the arterial graft for all the lesions. I'm using stent for all the lesions. And then we are debating. We are not debating the cost.
No, we are debating what is best for the patient in terms of surgical outcome. I mean, in terms of overall outcome, which is better?
Immediate
3 stents or 3?
Yeah, if you look at a recent Iraqi 2 trial, immediate results of multivessel angioplasty will be same or superior to a bypass. Long-term results, if we are talking of 10 years, 12 years down the road, even the venous grafts get occluded. What restenosis occurs is within the 6 months. After that, there is no restenosis, whether it's the balloon angioplasty or stenting.
Well, if I have a permission and interject, you know, if you look at various trials we have quoted, look at are we talking of 2 groups which are comparable? Whenever you compare 2 entities, you have to talk of 2 comparable groups. We are talking of Bari trials. There were 16,000 patients. Out of the 16,000, only 900 patients were found which were suitable for either angioplasty or bypass surgery, which were then allocated to the 2 groups. And if you look at Iraqi 2 and Iraqi 1 trials, then all trials in the world literature reported, I think 7 or 8 or 9 of them, only 10% of multivessel disease patients could be randomized to the 2 treatment. 90% there was no debate. There was bypass surgery was the only answer. Cardiologists granted that. It's only in 10% the debate came, shall we do angioplasty or we do that? Now then the comparison can't be there. You can't compare apple to oranges. You have to have the similar weightage to the 2 groups in complete, you know, spectrum of the florid spectrum of multivessel disease. Then